Okay, I think we're going to go ahead and get started. Welcome, everyone. My name is Roshni Matthew. I am one of the pediatric infectious disease physicians here at Lucille Packard at Stanford, and I co-direct the series with Dr. Alan Schroeder, who is one of our intensivists and hospitalists. Today, our session will be presented by one of our guest speakers, whom Dr. Schroeder will introduce in a minute. This will be our last session for the year. We had previously announced that last week was the last session, but we are pleased to say that we do have this session today. And I'm sure we'll learn a lot, especially in this climate of a surge that we are experiencing. In January, we will start with the COVID and the nervous system, and we have a wonderful panel there of neurologists who will talk on that topic. And the following week, we will have a session on multi-system inflammatory syndrome in children, or MISC, again, a panel of experts who helped develop our own pathway here at Lucille Packard. I will hand it over to Dr. Schroeder now. Thank you.
Thank you, Rajni. And Rajni and I are sort of flying blind today because we've lost our administrative support for the winter holiday. Bear with us for any potential technical snafus. But yes, thank you, Rajni. Thank you so much, Dr. Hametz, for joining us today. We wanted to add this because of the ongoing surge in California. And although we're not at a stage where I think we're really even close to having to do what Dr. Hametz will describe over the next hour, we obviously are worried about the current surge and how we will have to adapt to that. So when everything was going on in New York, I know many of us had what has been termed sideline guilt, because we felt as if everyone in New York was rolling up their sleeves while we were sitting largely really with empty emergency rooms and quiet hospitals. And so it's really exciting to have Dr. Hametz here to describe firsthand what happened, how they adapted, and maybe some of the lessons learned. Dr. Hametz is the chief of the Division of Hospital Medicine at Montefiore Children's. She is an associate professor of pediatrics and also the senior medical director of the Children's Hospital. So thank you again so much for joining us today, Dr. Hametz.
So thank you so much for that introduction, and thank you for inviting me. So I know this series is mostly focused on children with COVID. I'm not going to be talking directly about the impact of the disease on children, but I am going to describe its impact on our children's hospital. So I hope it'll be relevant to you all. So my objectives today are to hope that you learn different models of expanding surge capacity within a children's hospital responding to a pandemic, to identify challenges for pediatric staff to meeting the healthcare needs of adult patients, and to understand the factors associated with the successful transformation of our pediatric inpatient unit into an adult COVID-19 unit. So this slide is probably not necessary, but very quickly for some context and background, severe acute respiratory syndrome coronavirus 2 was first identified, as we all know, in January of 2020 after a cluster of patients with severe pneumonia presented in Wuhan, China. On March 1st, the first case was identified in New York, and on March 11th, the WHO declared a global pandemic. By the end of March, we had more than 75,000 known cases in New York State and more than 40,000 in New York City. And if you remember back in March, which seems like about a million years ago, we really were not testing broadly. We didn't have the capacity to do that. So that represented identified cases, but clearly was a gross underestimate of actual cases that were present. So this is New York, and I'm going to describe exactly what happened here in the Bronx, which is here. The Bronx is part of New York City, right up here. I hope you guys can see my pointer. Bronx has a population of about 1.4 million people. It is a very diverse community with 44% identifying as Black or African American, 56% identifying as Hispanic Latinx, and 9% only non-Hispanic white. It is the third most densely populated county in New York State. And just to give you a little bit of a sense of what happened here in the Bronx in the spring, of the 5 boroughs in New York City, the Bronx was hit particularly hard. This top graph you can see is the cumulative rate of known infections per 100,000. And by May 9th, when we were kind of over the peak and things were improving, you can see here we had 2,869 reported cases per 100,000. And as I said, this is probably a gross underestimate because we were only really testing those who were sick enough to come to the hospital. Similarly, the mortality rate was 285 per 100,000. And you can see in both graphs, the dark blue line is the Bronx. And we had the dubious claim to being the highest both infection rate and mortality rate across the city. So why was the surge so bad in the Bronx? And this is a heat map. You can see the Bronx, again, I hope you see my pointer, it's kind of up here. This is Manhattan, and here's the Bronx. And you can see this very deep red area that represents where the impact was the worst. And probably there are several likely contributing factors to why that was. First of all, the Bronx is home to a disproportionate number of service workers, those who we're also calling essential workers, who are essential workers, the folks who drive the buses, work at the grocery store, clean buildings. They could not shelter at home, and they went to work during the pandemic and interfaced with others, and really it was very difficult for them to social distance. So you can see, again, the density of service workers right up here in the Bronx. Secondly, the Bronx, as I said, is a very diverse community, and it's well documented that Black and brown people are faring worse with the pandemic. And again, you can see in the heat map that we have a high proportion of minorities. And thirdly, there's a high percentage of people who are considered rent burdened, meaning that they pay more than 30% of their income on rent, which is an indicator of families' financial fragility and probably a risk factor for poor health outcomes as well. And lastly, this one is a little harder to see, but if you look up here, again, looking at the colors, not the dots, but in the Bronx, there is a disproportionate number of residents who are living in overcrowded housing, again, up in this area. As you probably know, overcrowding has been associated with worse mental and physical health outcomes. And particularly in COVID, the overcrowding made it likely contributed to increased transmission of disease because of the difficulty of social distancing, quarantining, and isolating those in the household who were sick. So I work, as we said, at Montefiore Medical Center, which is in the middle of the Bronx. We care for the families and people in the Bronx community and the surrounding communities. The Montefiore Health System is an integrated health system of 11 hospitals. We have approximately 1,500 adult beds in the Bronx over 3 campuses, the Moses campus, the Weiler campus, and the Wakefield campus. Cham sits on the Moses campus. So here's Cham. We are a 140-bed quaternary care children's hospital on the Moses campus. We have 26 PICU beds, 114 med-surg beds over 3 floors, almost 9,000 discharges per year, and about 50,000 ED visits per year. And as I said, we're on the campus with Moses. We share the labs, radiology, pharmacy, and other services with them. And as part of the background, and this will come into play a little bit later, we do have a longstanding history and culture around quality improvement and performance improvement, which served us well, which I will talk a little bit more about later. Okay, so back to our story. So in March, we started to identify cases of COVID in early March in New York City. As the month progressed, the number of hospitalized patients with COVID-19 went from 7 to about 700 in the matter of 2 weeks. Hospitals became overcrowded, so the health system had to start to think about ways to increase surge capacity. There were plans to redeploy staff and utilize all physical spaces to provide patient care. So initially here at the Children's Hospital, we planned for a surge of pediatric patients, particularly in the ED. Even though the reports from China and from Europe indicated that children were not getting severe disease, we kind of braced ourselves for an onslaught. We thought maybe we'd get a lot of the worried well, like we saw during the H1N1 pandemic about 10 years ago. Ironically, though, Cham saw a dramatic decrease in the number of children who required hospitalization. So consistent with the recommendations of the Children's Health Association and others, pediatric care across the Bronx and in our local region was regionalized. Several local hospitals with small pediatric services closed their pediatric beds in order to accommodate for more adult beds, but our census still was markedly lower than normal. You can see the curve here, the blue line. We decided to expand our definition of what we call pediatrics to include care of patients up to age 30, but really neither of these adjustments resulted in a significant increase in our census. So essentially we had a functioning healthcare facility and capable workforce without many pediatric patients to care for, sitting in the middle of an overwhelming need to increase capacity for healthcare. So really we had two options on what to do, on how to reallocate the pediatric providers and nurses to care for adults during the pandemic. These two options are discussed actually in a Pediatrics Perspectives piece in the April 2020 issue of Pediatrics by Wolf and his colleagues. Although they were discussing the reallocation of ICU resources, the concepts are the same. First, a children's hospital can export resources by deploying providers to be integrated into healthcare teams run by and led by adult medicine providers. This can be done in a variety of ways, but requires that the pediatricians and nurses work in different environments with alternative team structures, as well as learn new practice routines and culture of care. In the alternative approach, patients can be imported. The pediatric team structure is maintained. Pediatricians lead teams of pediatric house staff and collaborate with our own nurses in our own hospital. The adult patients could come to us. This latter approach of importing the patients would allow us to work with a team that we were so accustomed to working with, keep our practice routines, and preserve our culture of care in a familiar physical setting. So the idea of having to surge in healthcare is not a new concept. After Hurricane Katrina devastated the Gulf Coast in 2005, the Joint Commission actually published a report on providing safe care in emergencies and surging. Healthcare systems have to be able to increase their capacity or their ability to quickly expand beyond their normal services to meet an increased demand for medical care in an emergency. In natural disaster situations, for example, this includes establishing temporary hospitals and compensating for damage to existing healthcare facilities because of the physical disaster. But when you surge in place, you learn to expand the surge capacity of a functioning healthcare facility. You go beyond the standard operating capacity to meet the demand for care. You can stay in your own environment, but you have to do things differently. The literature on how to do this, how to surge in pediatrics, is actually quite limited. There is one report that we found from 2009 that was done on behalf of the AHRQ, which describes recommendations for increasing surge capacity of pediatric hospitals to respond to large numbers of critically ill pediatric patients. It talks about staffing, triage, supplies, and many of the themes are actually similar to what we've seen play out throughout our system over the course of this pandemic. And it also talks about the unique challenges to pediatrics. And like other children's hospitals, we have an emergency preparedness team who think about how to do this. We plan, we practice these drills in the event that there's a large number of pediatric victims. But what this report from the AHRQ did not address, and we had not practiced, was what to do when the pediatric patients were not coming, and instead there were adult patients who needed our attention. So back to our story in March. We needed to find a way to respond quickly. Given the rapidly changing situation, the sense of uncertainty, and really the general sense of fear of the unknown, the decision was made that we would stay in Cham and we would surge in place. We would adapt our system to meet the demand for treating patients with COVID-19 and expand our staff's ability to care for adult patients in the children's hospital. So given the pace that the situation was worsening, we really had very little time. The governor had announced earlier that week that there was a need to immediately double the inpatient bed capacity across the entire city. The 3 adult EDs that comprised the Montefiore Medical Center had increasing number of patients waiting in the EDs for admission. So the decision was made on a Friday afternoon that we were going to open an adult COVID unit in the Children's Hospital by 8 a.m. on Monday morning. Because of the low pediatric census, we had actually combined 2 of our units into one the night before, so serendipitously we had an empty floor. Over the course of that weekend, the unit was created. It required a high level of coordination between physician and nursing leadership, as well as multiple other disciplines, including the pharmacy, respiratory therapy, the environmental service guys, and the central supply. Over those first 72 hours, we figured out enough of the plan, although other elements did continue to evolve over the first days as we began to take care of patients. Key tasks for physicians over that weekend included coordination with our adult colleagues, gathering protocols, and acquiring all the medical information we thought we might need, and determining staffing at the attending and resident PA level. The nursing team readied the unit with supplies, equipment, and staffing. Other key disciplines were the pharmacists who needed to expand the medications on the floors, the environmental team who would clean the unit, and the central supply team who had to trade out all of the pediatric supplies in order to make room for the adult supplies. So in thinking about how the unit was created and opened over such a short period of time, I think that there are really 3 critical elements that we should consider. And I'm going to briefly discuss each one of these 3. So first, structure of the unit. In determining how we would structure the unit, initially we considered organizing a split unit. One end of the floor would be the floor beds and the other would be a step-down unit so that we could kind of separate out the sick from the very sick patients and provide better care. But it really became apparent that the real and immediate pressure was to be as flexible as possible and to create as many beds as possible. And so that plan was revised to create a single 40-bed unit where we would care for adult patients at whatever level of care they needed, as long as they did not require ICU level care or intubation. We decided to divide into 3 teams of physicians to staff the 40 beds, each comprised of 13 or 14 patients. 2 teams were the responsibility of the Pediatric Hospital Medicine Service, who, although we were not expert in the care of acutely seriously ill adults, we were completely accustomed to the unit, to the physical environment. We know how to do inpatient medicine and we understand the workflow, and we work very closely with that nursing staff, so that was very natural and easy. The Pediatric Cardiology Division volunteered to cover the 3rd team. They too were accustomed to the environment and the staff on the unit, and they had more expertise in the care of critically ill patients, so it was a nice complement to our skill set. Because we were adding teams, and also because we decided that we needed to have 24/7 attending coverage in-house, we needed to expand the pool of providers. So we recruited faculty from other divisions, and we identified people who would be comfortable caring for acutely ill hospitalized patients. In general, these were attendings and specialties that provided a lot of inpatient care like oncology and gastroenterology, or individual faculty who were relatively young, so their residency training was a not too distant memory. Because the state of emergency had been declared, we were also able to obtain emergency attending credentialing for our senior fellows. In the end, we had 15 attendings from 9 divisions, in addition to the hospital medicine and cardiology team, and 4 fellows who were granted attending privileges, all caring for the adult patients with COVID. In addition, obviously, the teams required residents, PAs, fellows, and we had volunteer medical students as frontline providers. The staffing schedules had to change frequently to adapt to evolving needs and census, so we had people who were specifically assigned to just be doing scheduling. In addition to the direct medical care providers, our palliative care team, also known as QUILT, which is Quality in Life team, so hence the picture, was significantly expanded to provide extensive support to the patients and their families. In-house palliative care consultations were provided for patients who were facing decisions regarding advanced care directives. The team, however, mostly provided telephone-based services. There were supportive callers who called the patients and their families to check in, reassure, answer general questions every day. And there was a team of bereavement callers who called the family starting within 24 hours of a patient's death and continued to support them for approximately 3 weeks. The palliative care services team not only provided solace and care to the patients and families, but also they provided solace and support to the direct care providers as well. Through the notes that they wrote in the charts, the medical providers were able to learn more about their patients at a time that we were really discouraged to spend a lot of time in the room. So we couldn't sit and hear their stories, but through the palliative care notes, we could learn a little bit about them. The palliative care team also provided scripts and guidance to the providers to help us learn how to obtain healthcare proxy and advanced directive information early in every admission, which as pediatricians is obviously something that we were not used to doing and not completely comfortable to do. So as soon as we decided we were going to create this unit, we obviously reached out to the leadership of the hospital medicine division in the Department of Internal Medicine. We knew that it would be absolutely critical for them to be able to support and assist us while we were taking care of adult patients. Fortunately, they recognized the need as well. And at the same time, they were providing support across the system to providers who were in positions where they were not normally taking, providers who don't normally take care of hospitalized patients were being asked to do so. So they developed a cadre of what they called adult hospitalist advisors. So for the first 3 days our unit was open, we had an advisor on site. They helped us adapt our workflow to mimic the care they were providing on their units. They helped us to figure out how to identify the really sick patients, since they all looked pretty sick to us. And they gave us a crash course on management of common adult chronic conditions, including diabetes and hypertension. And they brought us donuts. We also had the help and support of the Popcorn Network. As many of you know, this is a network created by the Peds hospitals at Cincinnati Children's. It has become a national network. They made themselves available to us and continue to do so for other programs, available 24/7 by phone to provide telephone consultation for any questions we had about managing adult illness. Another key to our success in being able to function independently was that from the beginning, there was a recognition that it would be beneficial for all of us to consider the most appropriate patients for the unit in Cham, in our building in Cham. We agreed that we could not screen patients based on the severity of COVID symptoms, as long as they were not already needing ICU level care, but that it was appropriate for us to try to limit the number of comorbidities the patients had, since we were not expert in taking care of those comorbidities, those underlying illnesses. So we wrote some guidelines as a first screen, and those included that the patient had to have COVID as a primary diagnosis. They couldn't be coming in for something else. We initially wanted to try to limit it to patients who were 50 years or below, thinking that they would presumably be less sick with less chronic illness. And we tried to limit it to no more than 2 major organ dysfunctions. And really things like hypertension and diabetes, we did not count as major organ dysfunctions. Really things that were more complicated than that were considered. So screening, though, proved easier said than done. Because of the volume of patients they were managing and their workflows, we couldn't talk to the adult ED providers to discuss the patients before they came upstairs. So instead, we worked with the admitting office. They too were under extraordinary pressure to assign available beds and were told that they were not allowed to hold patients in the ED. So that whatever we were going to do to try to screen the patients before they came up had to happen really quickly. So we set up a system whereby the admitting office would call our charge nurse as soon as the patient was targeted for our unit. The charge nurse immediately screened the chart to determine if the patient met these criteria. The criteria were not meant to be exclusions, but meant to say that if they did not meet these, this set of criteria, then an attending physician would immediately review the chart to determine appropriateness for the floor. That process worked pretty well, though as we became more accustomed to caring for adult patients and the need became more urgent and the patients came faster, our comfort level rose. And as the month went on, we really did take care of more and more patients. So these criteria became a little less relevant. We took on patients who were significantly older than 50, and we did have patients with increasingly complicated comorbidities. So the second major consideration is we relied on a rapid cycle learning system. And this is where our strong foundation and quality improvement work really played to our advantage. Many people were already familiar with the concept of rapid cycle learning. And over the previous month, the environment, our knowledge, our inpatient population were all changing and evolving so quickly that we had to adapt and make changes and disseminate information quickly. So just a couple quick examples. In terms of institutional changes and evolving guidance, there were nearly daily changes about practices. And, I'm sure you all remember back to the beginning of March where we really were just trying to figure it out as we were going. So decisions about who we were going to test for COVID, who we were considering a PUI, a person under investigation. We were learning that the information was evolving as we better learned to recognize symptoms, as the prevalence of the virus increased, and as testing became more available. Our isolation policies changed nearly daily, again, as we better understood risks for transmission. And with the understanding of risks and also the ever-changing concerns about availability, our guidance about PPE use and reuse was adjusted frequently. So we learned to evolve quickly and change on a dime. In terms of care guidelines, although there was some experience in managing patients in China and in Europe, at the beginning of March and in the middle of March, there was relatively little known about how to care for patients with severe disease. So again, practice guidelines changed frequently regarding anticoagulation, steroids, antibiotics, antiviral use. We tried to keep abreast of official websites and listservs. We borrowed from other institutions. We learned while we practiced, and we tried to study our data in real time. Our best practices evolved and had to be adopted as well. Just as an example, on a more local level, nearly overnight, we changed from standard use of nebulizers for albuterol administration to almost exclusive use of MDIs in order to minimize aerosolization of respiratory particulate matter. Under normal circumstances, this kind of change probably would have taken us many PDSA cycles and many months. So to accomplish the rapid cycle learning and adaptation, we had over the previous weeks increased communication via meetings, daily briefs, and huddles. We sent out regular emails through the hospital leadership to keep everybody informed so that we could make rapid workflow changes and information could be disseminated quickly. We set up a web-based team site so that protocols and guidance could be updated and so we could minimize confusion around and have as good version control as possible as documents were circulated and recirculated as we changed our guidance and our practices. So we also, the rapid cycle learning was not limited to learning medicine and medical protocols. We needed to learn how to meet the challenges that really, and this word was so overused, but really true, were really unprecedented. In the clinical realm, we had to learn how to recognize and treat the adult medical concerns while easing their anxiety. In our interactions with patients, we had to learn how to communicate differently with the patients. It was hard to learn how to talk to patients through the mask, the eye shield, fully gowned and gloved, and with the recommendation that we don't spend a lot of time in the rooms. And we had to learn how to comfort families over the phone. We also had to learn how to take care of ourselves, how to make sure that we felt safe in the care we were providing, to accept uncertainty about what was going to come next. And we had to learn how to leave it behind a little bit when we went home at night so that we could come back the next day. This learning was facilitated again by the leadership daily updates via email, really trying to keep people informed. We had at least bi-weekly meetings of providers at multiple levels so that people felt a sense of connectedness and a sense of knowing what was going on. Respite rooms were created, and we tried to eat together when we could. Of course, now the guidance is we're not allowed to do that, but in March we did that, and that really provided a lot of solace for providers and helped us learn how to adapt quickly. So the final element that helped us to be successful was an intentional effort to maintain as many of our familiar systems of communication as possible. Some of this did take a little bit of time to figure out. For example, one of the first times we needed to intubate a critically ill patient on the floor, we realized that we really hadn't figured out a streamlined process for escalation and for communication. We needed the special expertise of the adult RRT team, but we also wanted the rapidity of response that we got from our pediatric team. Once the patient was intubated and waiting on the floor for an ICU bed, we needed providers who could manage the vent and take care of the ICU management while we waited for nearly 6 hours for the patient to get an ICU bed. Ultimately, we decided that care escalation would be a collaborative effort between the pediatric response team from our ICU, the adult response team, and the floor-based hospitalists and cardiologists and nurses. But it did take us a little while to figure out how to clarify those roles and responsibilities, and really required some explicit conversation and discussion. A second way in which we preserved our familiar structure around communication was in calling consults. The department agreed after much discussion that for consultations to subspecialists, we would call our pediatric colleagues, who would decide whether they needed to confer with their adult counterparts. This minimized the need to further burden the already overburdened adult subspecialists, as well as enabled us on the front lines to work with those people who were really familiar colleagues. When there were instances in that the pediatric approach was different from the adult approach, we could also use the adult protocols with the guidance of the hospitalist advisor without needing to reach out to the adult subspecialists. A third way in which we maintained communication was within the teams themselves. For the first few days, because we were so busy and distracted and just trying to get accustomed to our new patients and their care, we were skipping our 7:45 morning brief. We quickly realized, though, that we could and should maintain our normal workflows and normal communication paths, even if the patients were different. Rather than being an interruption, these communication channels and routines were essential to maintaining our situational awareness and our teamwork between the physician and nursing teams. So how did we do? So from Monday, March 30th through Thursday, April 23rd, about 3.5 weeks, we admitted 147 adult patients, all of whom are over the age of 30, with severe acute COVID-19 disease. As an aside, we were still admitting the 30 and younger to our quote unquote pediatric floor, and they are not included in these data. So in order to describe our demographic and clinical characteristics of our patients and to give some context for the outcomes, I'm going to show you results from 3 other studies that were available at approximately the same time. Although there are many more studies now and the outcomes have overall improved from what I'm going to present here, I want to show in comparison to these particular studies because they represent the results from early in the pandemic when our unit was active. The first study was published as a research letter in JAMA describing 377 hospitalized patients in the Northern California Kaiser Permanente system, which you guys are familiar with. It is a retrospective cohort study of adults hospitalized in one of their 21 hospitals during the month of March. The second was a study done by the research team at Northwell Health, which is here in New York City. They described 5,700 patients of all ages hospitalized in their 12 hospital system from March through April 4th. Across their system is part of New York City into Long Island mostly. And they had 44% of the patients had outcomes included in the study that were known at the time. And then the third study was out of the 2 largest hospitals in China where adults with COVID were cared for. And that study included 191 adults who had who had outcomes that were available at the time of their publication. Okay, so here are the demographic characteristics of our 147 patients that we cared for on our Cham unit. As we described earlier, we did aim, at least initially, to capture a younger population, so the median age was about 47 years. The vast majority were male. 1/3 of our patients were Black or African American, 44 were Hispanic, and 1/4 of the patients spoke a language other than English, and of those patients, Spanish was the overwhelming majority. Comparing this cohort to the other cohorts described, remember that each of these studies was done very differently, data were collected differently and analyzed, so It's not really comparing apples to apples, but we'll give you some sense. And for the other hospitals, I'm only showing the percentages, again, just to give some idea of how their populations, how our population of patients compare to the others. So you can see, compared to the cohort at Northwell, we had a higher percentage, we had younger patients than the other, compared to all the other three cohorts. In terms of race and ethnicity, we had a higher percentage of Black patients, Hispanic patients, and those who were not primarily English speaking compared to Northwell Health. The other two studies did not describe the patient populations. And this is reflective of the patients in our local communities of both of the systems. So clinical characteristics of the patients at Cham. As I said before, it was our intention to limit the number of pre-existing conditions and comorbidities of the patients we took care of. So for this study, we looked specifically when we did the chart review at the comorbidities that are most frequently associated with poor outcomes based on the prior literature at the time, including obesity, hypertension, diabetes, heart disease, and respiratory disease. Half of our patients had one or fewer comorbidities documented. Of those who did have comorbidities, you can see obesity and hypertension were the most common. The Charleston Comorbidity Index is a measure of total comorbidity burden. It predicts 10-year mortality for a patient based on age and the number of serious comorbid conditions. It's based on ICD-10 codes that exist within the electronic medical record, and it was calculated through our electronic data extraction tool when we pulled these data. The lowest score is 0 and corresponds to an estimated 98% likely 10-year survival rate. So the fact that over half of our patients had a score of 0 again reflects the fact that our patients were in general younger with fewer comorbidities prior to them getting COVID. The rate of obesity in our patients was similar to that reported at Northwell Health, and the data on obesity was not available for the California or the China cohort. In addition to obesity, hypertension, and diabetes were reported in all 4 studies. And you can see the numbers here. Well, we did try to limit the number of pre-existing comorbidities. As I said, we did not limit our patients based on disease severity due to their COVID-19. With the exception, obviously, we did not take patients on the unit who were already requiring critical care or intubation in the emergency room. Looking at the Cham numbers, overall, our patients were pretty hypoxic on arrival to the floor. 57% required nasal cannula on admission, ranging from a few liters to 10 liters per minute. Ultimately, 1/4 of our patients required 100% oxygen on a non-rebreather. Many stayed on the non-rebreather for days. 4% required high-flow nasal cannula on the floor, and 16 patients, or 10.9%, ultimately required mechanical ventilation. We kept patients on the floor until they actually required intubation and mechanical ventilation. Unlike normal times, a patient on non-rebreather would typically not be on an inpatient floor, but given the number of severely ill patients in the hospital, that was the most appropriate thing to do. So that of the total of 16 patients who required mechanical ventilation, they were all emergently intubated on the floor and subsequently transferred either to the PICU or to an adult ICU, depending on where the beds were available. One patient did die on the floor shortly after intubation and therefore did not get transferred. In addition, 6 patients needed dialysis, which was done either on our unit or up in the ICU, depending on their other needs. And in particular, if they were intubated, they went upstairs to the unit, and if not, they stayed on the floor. Comparing to other studies, the proportion of patients who required mechanical ventilation and ICU admission was similar to what was seen in Northwell. However, it was much less than what was reported in California. Again, this is likely due to a lot of confounding factors, including age and comorbidities. At Cham and really throughout Moses, due to limited ICU bed availability, as I said, we kept the very sick patients on the floor as long as possible. Whereas in normal circumstances, these were patients who really would have been in an ICU. Therefore, when we're talking about ICU admission, it's a little difficult to compare across the different systems because we have limited information as to what care escalation looked like in each of these systems. So the disposition of our patients, ultimately 91% were discharged home and 9% or 13 of our patients died. Of the 13, 4 died on our unit. And of those 4, 3 had DNR orders in place. And the other was the patient that I mentioned who died soon after being intubated on the floor. 9 died after they were transferred to the ICU. The overall length of stay was 4 days with an interquartile range of 2 to 9 days. So there were a lot of patients that had short lengths of stay, but there were a few patients who stayed in the hospital for many weeks. Comparing to the other hospitals, our mortality rate was less than those in the other studies, though again, hard to compare because our sample was intentionally biased. And not all of the outcomes were reported for the patients in the other cohorts because they published while some of those patients were still presumably admitted. However, we would expect our mortality rate to be lower and lower also, excuse me, compared to our own system, since we were preferentially taking the younger and healthier patients. And at that time, just for comparison, the overall mortality rate in our system was about 20%. So fortunately, we've come a far way in the care we're able to provide. We've learned a lot about the disease and how to manage it. Mortality at our institution and across the country is much lower than these initial numbers. So some conclusions and why it worked. So first, we were familiar with our teams and our environment. It was one less thing or a few fewer things that we had to learn quickly. Our foundations in quality improvement allowed us to quickly adopt methods of continuous learning and ongoing performance improvement. We stretched our capabilities, but we knew our limits and we knew when to get help and how to get it. And really, there was an amazing sense of community support and camaraderie. People rose to the occasion and really just jumped in and rallied in a way that was really phenomenal. And as hard and as difficult as it was really amazing and really brought our teams together to be able to provide the care that we needed to provide and to do our part. So fast forward to December 2020. Unfortunately, as you guys know just as well as we do, case rates and hospitalizations are continuing to climb across the country. As I said, fortunately, the case fatality rate at least is lower. I think that the hospital systems now are facing a little bit different challenges than we had compared to those we had in March. In March, there was really a complete shutdown of everything else. All other hospital business stopped, for better or for worse. Elective surgeries were canceled, ambulatory visits were canceled. People didn't want to come to the hospital because they were afraid of getting sick. So, and as I showed you before, our pediatric non-COVID census remained really low throughout the whole spring. So we could focus virtually all of our efforts on taking care of the patients with COVID, first the adults and then later the children with MIS-C disease, when we needed to do that. Now, I think we and other hospitals are faced with a need to balance a variety of needs. We have the patients with COVID, though fortunately for us, many fewer than we had in the spring. But we're also conducting much of the business as usual. We have normal admissions, we have elective procedures, we have ambulatory visits. So this is leading us to have to really rethink again how to creatively use resources. We need to meet the challenges of cohorting patients, maintaining social distancing in the healthcare setting, with less bed availability and space because of the need to social distance and cohort. And there's also less staff flexibility. As I mentioned in the spring, because all the ambulatory services were shut down, we really could pick people from our subspecialties to help us so we could expand our workforce very quickly. We don't have the sort of luxury of doing that now because everybody is continuing with their normal responsibilities. So that's a challenge, which we're figuring out how to balance all that, and as I'm sure other hospitals are doing now as well. In addition, I think that in the spring, as I said, there was a real sense of camaraderie and a sense of calling, and people wanted to really jump in and help. I think now there may be a little bit of an increased weariness among providers and staff, as what we hoped would be an intense but short sprint has really turned into a long haul. This is being fortunately counterbalanced by the arrival of vaccine. And I think that regardless what happens, the lessons we learned focusing on our models of care and structure, using rapid cycle learning and good communication are all going to continue to help us to adapt in real time to meet the needs of our patients, to help support our hospital and our community. So I want to acknowledge a few people, Dr. Caitlin Phillips, who is one of my colleagues who did all the data collection and analysis that I presented, to Dr. Phillips and Dr. Catherine O'Connor, who collaborated with me on an earlier version of this presentation. But really, I want to thank deeply my division of hospital medicine, our whole Department of Pediatrics, and our internal medicine colleagues who really helped get us through all of this. I am happy to take any questions.
Thank you so much, Dr. Hametz. That was really helpful. And I have lots of questions, and some of them are starting to pile in the Q&A for us. Wanted to just comment real quick. One of your earlier pictures, I noted there were a bunch of people in a crowded room without masks, which was, of course, I think a reflection of very early on in this process. None of us really knew what to do, and I sometimes wonder if some of the hospital acquired, the healthcare worker acquired infections had to do with the fact that maybe we weren't distancing in the hospital. But I'm curious, how were the infections? I mean, obviously the exposure to a lot of patients, PPE concerns. Did any of your staff get infected?
Yeah, so just to caveat, that picture that I showed with all of us in the crowded room was actually our Christmas party a few months prior.
Okay.
So that was pre-COVID. So, your question's a very fair one, because early on, there wasn't clear guidance about mask usage, and really there was a concern that we were going to run out of masks. So there wasn't a strong recommendation for people to be wearing masks, except when they were dealing with patients for the first, I'd say, until kind of the mid to end of March. So did some of our people get sick? Yes. Fortunately, nobody in our group got severely ill enough to be hospitalized, but there were people that were out for several weeks in a row. Interestingly, we do not think, based on when they got sick and what their exposures were, that they got sick while taking care of patients. It's exactly what you said, that they got it either from the community or from colleagues in the hospital. We didn't have contact tracing at the time, so I don't know this for a fact, but again, based on who got sick in our group, I do think that it probably was a little bit of sharing amongst ourselves. Yeah. That was early in March. Once we opened our unit and we all started wearing protective equipment, the PPE, nobody got sick, which Great. Was really amazing.
Well, really inspiring work, and thank you again for sharing. I'm going to just try to field some of these questions here. The first one is about documentation requirements, and then maybe you can add to that anything about billing. How did all that pan out?
So again, fortunately, our adult colleagues shared, they had put together a sort of a templated note for the care for adults with COVID. So we used their templated notes that we really were able to document pretty well and carefully. And then we billed, I think that is one thing that we thought about after the fact, that had we really focused on that, we probably could have been much more consistent. Some people billed at sort of a level 3. Some people, for the patients who were on non-rebreathers and high flow, we billed at critical care billing levels. So that all, again, with the help of our adult colleagues, we got that in place pretty quickly.
What about, I know people have been concerned about medical legal issues as well. How did you handle liability and licensing and credentialing and all of that?
Yep, so that's a great question. We, it actually, because of a longstanding conversation, and you guys may have a similar situation where some of our subspecialists like to hold on to their patients after their 21st birthday. So we have the 25, 26, 27-year-olds patient from the neurosurgeons or the oncology patient. So we had about 6 months before that decided to put a clause into our credentialing that if the patient was in our building, regardless of their age, that we were credentialed to take care of them. So that from a medical legal standpoint, it was in our credentialing that we could take care of them. I think in terms of the sort of legal liability, the state had been declared a disaster area, and it was an emergency situation. So I think that we all felt comfortable enough that we wouldn't be held liable. It was a question that came up. We were reassured, again, enough by the hospital leadership that given the fact that it was an emergency declared by the state, that we would not be held liable. And just to add to that, I think it was really interesting. We were really worried that the patients coming into our building would be furious that they were being cared for by a bunch of pediatricians. There was not one patient who was unhappy with the fact that they were being cared for by a pediatrician, because they were just grateful that they were being cared for. And I think, as awful as that sounds, it was incredibly reassuring to us that we knew we were doing the best we could, and our patients knew that we were doing the best we could. So that concern went away pretty quickly.
Well, I think you could argue there's a level of attentiveness, without any disrespect to our adult medicine providers. There's probably a level of attentiveness that we're used to in dealing with families and small patients that is a benefit. So your old friend Jessica, go ahead.
So, and we were told that we did have patients saying, oh, when I've been admitted onto the adult side, they never did that for me.
Right. Your old friend Jessica Gold is asking about code status discussion. Did you guys initiate them? I know you mentioned, I think, that palliative care was involved, but how did that all work?
Yep. So we had a script that every time we went and did an H&P on an initial admission, we asked them who their healthcare proxy was, and we had a script to ask them what they wanted their code status to be. Some patients changed what they thought over the course of their hospitalization, but we did learn very quickly how to have that conversation. It was not an easy or comfortable thing for us to do, but again, our palliative care people really provided a script that was helpful and made it comfortable enough. If those conversations got complicated or there was really an acute crisis around that, we called a palliative care consult, and our palliative care specialist, who was trained, came in and helped us out. But there were just so many patients, she couldn't do it all herself.
It must have been just so foreign to be dealing with these incredibly challenging issues with no family members available.
Yeah, that was the other thing. It was tough. And what we did try to do, again, we either used people's cell phones or we had some iPads. We would do FaceTime with them, and while they were deciding about their code status, we would let them, for as long as they could talk. And unfortunately, a lot of times they were in so much distress, it was hard for them to do it, but they could talk to their family members, and their family members would be guiding them. But it was hard because we were in the room, we were literally holding the phone for the patient, and there for conversations that were incredibly intimate and hard to hear.
Yeah. There's a question about, I guess, asking you to speculate on what you think the long-term impact on pediatric regional care systems will be. Will it help reinforce the value or create additional challenges?
So that's a great question. As I mentioned, we did in the spring, several of the smaller pediatric services in the Bronx and in Southern Westchester did close and sent their patients to us. We wondered the same if those smaller services, because New York City is, different than other places. When we say the community hospital and you think of something 50 miles away, our community hospitals are, 5 miles away, 2 miles away, 10 blocks away. So the regionalization would conceptually make sense. But those pediatric services that had closed did reopen. And what the long-term impact is going to be, I really don't know, because this summer and fall have been so unusual in terms of all of us have low volumes that I think people are a little bit holding their breath to see kind of how things sort themselves out when things get back to whatever normal is going to be before they decide what those centers will look like. So I do know that there was one sort of community hospital that was planning on trying to expand their pediatric services, and that plan is on hold. Again, rethinking the strategy and rethinking the regionalization, but I'm not sure that we know yet what that's going to look like.
How many of the other local hospitals did something similar to what you did in New York and New Jersey and Connecticut, really? I guess all were so burdened at that time.
Yeah, so most of the other hospitals in the region, I think all of the other hospitals expanded what they considered to be pediatrics to either 25 or 30 years old, so that they help to take care of the younger adults. Most of the other hospitals in New York deployed their pediatricians to work on the adult services as opposed to, so they exported resources rather than importing patients. I don't think that anybody else, as far as I know, opened a complete adult unit with the age range that we had.
Great. Well, I had one last clinical question. I noticed when you talked about your respiratory support that a lot of people were on non-rebreathers and very few were on high flow. And I think people are, and I'm wondering if that was out of concern for, there has been all this discussion about aerosolization of high flow. Was that part of the rationale, do you think, or was it less? What led to that difference?
Yeah. So that was part of the conversation, was the question about the aerosolization. It was also driven by resources. We were running out of high flow machines.
Interesting.
So, and the escalation was really people were on non-rebreathers. If they were not doing well on the non-rebreather, we would often try high flow before we intubated them, but sometimes we just went from non-rebreather to intubation because it was clear that they were not going to do well. But the preference for the non-rebreathers was partly because of resources.
And building on that, you said a couple patients at least went to the PICU. What was the reflections of your intensivist? How did that go?
So the PICU at the same time, they not only received patients from our floor, they actually received a few patients from the adult medicine floors because the adult ICUs were so crowded. So, I think it was similar to us. They, in some sense, once the patient was intubated and mechanically ventilated, a lot of the care was not dissimilar to what they were used to doing with ventilated mechanically, ventilated patients. They also relied on their adult counterparts with the complicated adult medicine issues that they were not familiar with. So I think it was relatively similar to our experience. They did not have, but they had a mixed unit, right? They still had pediatric patients mixed with the adults. So they had a proportionately smaller number of adults.
Yeah, I think it's gout that scares me the most. It'll be interesting to see if we get there. But listen, we're at the hour mark, and really thank you so much for lots of comments coming into the chat. Thanking you for the inspiring story. We appreciate it very much, and lots of respect to everything that everyone did in that area during these challenging times. So thank you so much.
So thank you all. All right, take care. Be well, everybody.
Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.